This is a case of a 20-year-old male who suffered a dreadful tire burst injury. He came in with a post-traumatic cataract, a 4 o'clock hour iridodialysis and vitreous hemorrhage that was noted on the B scan. Hence, he was advised a lensectomy, a vitrectomy and an iridodialysis repair with or without tamponade, seeing the condition inside. The case was started with a 3-port pars plana lensectomy. Here, since the patient was young, the nucleus was expected to be extremely soft. So without damaging any part of the iris, a complete lensectomy was done and the vitreous in the anterior vitreous phase was cleared. Once this procedure was done with the help of a biome, a core and a peripheral vitrectomy was completed. But while doing a peripheral vitrectomy, I see an area of pars plana detachment. The posterior vitreous detachment was already present. Hence, very carefully after removing the dropped lens matter, a complete base shaving was done. Once the base shaving of the superior retina specifically was done, a laser barrage was done, that is, an aura-to-aura laser barrage was done to prevent the further extension of the pars plana detachment. Once the laser was over, it was time to repair the iridodialysis. Here, a railroading technique was used. A groove was made with the help of a crescent knife 1.5 mm away from the limbus. Once this groove was made, a double-armed 9-0 prolene was used from the other end and a railroading was done with the help of a bent 26 gauge needle. In this technique, it is very important to note that the needle should pass from the root of the iris and not from the central area. Otherwise, there might be retraction and secondary uveitis later on. Also, it is important to make sure that the tie is not extremely fit. It should be just a snugly fit tie and the knots can be buried inside the groove. So the knots are taken in a 3-to-1 manner and then nicely buried inside the groove. Once the sutures are over, a max grip forceps is taken and the tip of the iris is slightly retracted forward. Once this is done, the conjunctival peritomy is closed. The pupil now looks decently round, hence the surgery is ended by doing an air fluid exchange. 1 month later, since the disc and macula were healthy, the vision improved to 6/12 with a +12 correction. In these cases, an option of an iridic SFIOL should always be given to the patient, but since this was a one-eyed patient, he was extremely happy with the aphakic glasses that were photochromatic in nature. Hence, a secondary procedure of an iridic SFIOL was deferred for the time being. Thank you very much for watching.